Welcome to the perinatal class on video at Colquitt Regional Medical Center. My name is Monica and I'm one of the labor and delivery nurses here. I've had the privilege of working with Colquitt Regional for almost 12 years, and I speak for all the nurses on our unit when I say we love what we do. The providers you see love what they do also. You're in great hands with them. They are the best of the best, and we always look forward to working with them and you when the time comes. We also love offering these classes, and I'm so glad you've joined us. We just believe that providing you with real-time information and a close-up look on how we do things just gives control back to you and empowers you as a new mother about to give birth and builds confidence as you become new parents. So just relax and make yourself comfortable. I want you to have a great time of learning with us. There is a vast amount of information I want to impart, so just hang in there. The beauty of watching by video is you can push the pause button and take a break anytime you need it. Okay, so let's get started. Instead of just jumping straight to the good part, we're going to try to start on the outside and work our way in. I would like to talk about two conditions that can happen during pregnancy, so it's important to understand the signs and symptoms to look for. The first one is understanding hypertension and preeclampsia. What is preeclampsia? The truth is it's really not well understood, but most scholars do believe that it's related to a placenta that for whatever reasons is no longer functioning the way that it should. It's also called toxemia, if you've heard of that word, and it is a pregnancy and sometimes postpartum condition that is characterized by high blood pressure. It most often occurs after 20 weeks of pregnancy, but sometimes can develop after delivery, a condition we would call postpartum preeclampsia. Preeclampsia often occurs in women whose blood pressure has been perfectly fine, so that's the weird thing about it. The signs are not always obvious if you are not checking your blood pressure regularly, so that's why it's extremely important to go to all of those doctor's visits, even if you're not feeling anything outside of the ordinary. You know, they check your blood pressure every time that you go, so they've got the record from the beginning to the end and can tell the little trends and changes in that blood pressure, so it's very important. So, blood pressure that exceeds 140/90, documented on 2 occasions at least 4 hours apart, is considered abnormal. This rise in pressure is often the first sign of preeclampsia. This can happen slowly over time or come about suddenly. There are 2 categories of preeclampsia, the mild form and the severe. So let's talk about the signs and symptoms. Now, not a single high blood pressure reading, especially after you rushed around all morning trying to get to that doctor's appointment on time, means that you have preeclampsia. It should be rechecked again before you leave the office. Your doctor is going to be looking for several high readings, unless of course it's just through the roof. Some swelling, as you know, is completely normal during and after your pregnancy, but if you're noticing something outside of what's normal for you, particularly the excess swelling in your legs, hands, and especially the face, you certainly need to reach out to your doctor for that. Sudden weight gain of about 2 to 5 pounds in a week could also be a sign of preeclampsia creeping in. Now, headaches that won't go away, especially ones that respond to Tylenol, that would be related to high blood pressure, so of course that's a problem. If you have beyond what's normal for morning sickness, like excessive nausea, vomiting, and dizziness, that's a sign as well. Any changes in vision, including light sensitivity and blurred vision, should immediately be reported to your doctor. Now, there's nothing comfortable about carrying a baby around for 9 months, but if you're feeling a sharp pain in your abdomen, usually up on the upper right side near the ribs, that is what a red flag of preeclampsia can be. Now, you know pregnant women should be peeing a lot. We expect that. So if you notice any changes in the way that you're urinating, especially if you're doing it a lot less, that's also a bad sign. So, if you have elevated blood pressure during one of your routine OB appointments, they might send you over to see us for urine and blood tests. Or if they suspect you might be on the threshold for something, they might just watch you until your next appointment. It's pretty simple to pinpoint, but it is extremely crucial to treat. There are lots of options to keep you and your baby safe, but delivery is considered the cure for preeclampsia. So, if you're close enough to term and your doctor feels that your baby's developed enough, you'll most likely be headed over to us for an induction or a C-section. Now, preeclampsia alone won't land you a C-section. The reason for that would be is that you're just not close enough to term yet and your baby may still be in the breech position. So, what happens if your preeclampsia diagnosis comes way too early in pregnancy? Well, your doctor would want to keep a close eye on you and the baby with more frequent appointments for blood pressure checks and teach you how to monitor your blood pressure at home. They would also have more ultrasounds and non-stress tests on your horizon versus a more typical pregnancy. You should be able to monitor your baby's movement by doing what we call the kick count test. Make sure there's no decrease in fetal movement and that you're able to lie down and feel your baby move approximately 8 times within an hour. And that's really a great thing to do regardless of a preeclampsia suspicion. Blood pressure medication may be prescribed for you, and you may get steroid injections. We call those corticosteroids. They are useful in severe cases of preeclampsia. They can help to improve your liver and platelet function, as well as boost baby's lungs in preparation for an early delivery. Anti-seizure medicine may also be prescribed for you to reduce the risk of seizures if your blood pressure becomes too high. So, let's not open the door to this thing. Always try to avoid fried foods, maintain a low sodium diet, stay hydrated, avoid alcohol and caffeine during pregnancy, rest on your left side as frequently as possible, and anytime you're able to sit during the day, elevate your feet and get plenty of regular exercise. The next condition would be understanding preterm labor. Preterm labor is defined as the threat of labor anywhere between 20 and 37 weeks of pregnancy. Going into labor before the 37th week can lead to a number of health problems that may affect your baby. Remember, the goal is always a full-term baby. Before labor, your cervix is what we call thick and closed. So in preterm labor, the cervix would begin to thin and open. If you think you're having preterm labor, get medical help right away. Call the office or come straight to labor and delivery. Contractions alone now don't mean that you're in preterm labor. What matters is, are there any changes to your cervix? Symptoms of preterm labor would include contractions every 10 minutes or more often with abdominal tightening, cramps that feel like your period, leaking of fluid or vaginal bleeding, pelvic pressure that feels like your baby's pushing down, and a low dull backache. If your cervix is still thick and closed, your provider may tell you to drink plenty of fluids, do fewer activities, rest in bed on your left side, and refrain from any form of intercourse or nipple stimulation. If you need hospital care and come to us, it is possible we will do the following things. We will do a pelvic exam to check for cervical thinning and dilatation, put you on the monitor to see those contractions and check on baby, and we might even order an ultrasound to check your cervical length and check on baby's size and position. You may get IV fluids, pills, or injections to stop labor and prevent those contractions. Finally, you may also get steroid shots, just like the ones we talked about with preeclampsia, to help mature baby's lungs. You are at risk for preterm labor if you smoke, use drugs or alcohol during pregnancy, if you're pregnant with twins, if you are told that you have a shortened cervix or problems with the shape of your uterus, if you are experiencing bleeding problems during pregnancy, or even a stressful life event, maybe a sudden unexpected death in the family can also trigger preterm labor. So just remember, babies born too soon just don't have enough time for growing, and they may have low birth weight, vision problems, breathing problems. It puts them at risk for cerebral palsy and learning disabilities, even bleeding problems in the brain. Babies born too soon with critical problems like that are transferred out to hospitals with higher levels of NICU. Your goal is always to get as close to term as possible before giving birth, because the closer you get to term, the higher your chance is of having that healthy baby. Okay, so let's talk about what to bring to the hospital, and that list is included in your folder as well. So I'm not going to read the whole list, but there are 3 things on there that we would like you to know about. Please go ahead and choose your pediatrician. We need to know who to schedule baby's first follow-up appointment with, so we will ask you what your choice is. The other thing on here that's really a helpful reminder is an extra long charger cord. And that's just because the way our beds are set up in relation to the outlet, you're going to be extremely glad that you brought an extra long cord. So, always remember any time that you come to see us at the hospital, always stop at the front lobby and get registered first before coming back to labor and delivery. They will get you all settled and bring you back to see us in a wheelchair. Unless, of course, you have a funny look on your face or you're sitting sideways in the wheelchair, they'll probably skip all the paperwork and rush you straight back to us. Okay, the next thing is let's talk about real labor, how to recognize it, the real versus the false alarm. And there's another name for false alarm called Braxton Hicks contractions. So let's compare the differences. With false labor, you're going to notice the contractions right in the front of your belly, but the pain goes away whenever you change positions or even hydrate yourself with water. True labor contractions, they usually start in the back and kind of creep around to the front, and they do not get better when you switch positions, move around, or rest. Now, Braxton Hicks, we're not going to tell you they don't hurt. They certainly do feel like the real thing, but they are only rehearsals for the big day. If it is true labor, they're going to occur at regular intervals, follow a pattern, and get stronger, longer, and closer together over time. Contractions that intensify over time are the real things. Nothing will stop that true labor train from coming. They do not ease up with a change in activity or position. Each one feels like a very strong menstrual cramp, because the purpose of true labor contractions is to thin and dilate the cervix, and that's what causes the pink-tinged bloody show that might appear on your underwear, or you might see after wiping when you go to the bathroom. That usually indicates there's changes going on to your cervix. So, the difference is usually connected to the frequency, intensity, and the location of the contractions. Here's the secret. True labor contractions will absolutely get painfully stronger, they will absolutely start lasting painfully longer, and they will absolutely get painfully closer together. So 3 key things: stronger, longer, and closer together. Now, 2 conditions that can stir up Braxton Hicks, the false labor, would be UTIs. So we can have women that come in complaining of contractions, put them on the monitor, and they're just popping those contractions out one right after the other. As soon as we get their urine results back, we see they have a UTI, so it's really easy to manage. So the second option that causes these is also dehydration. So make sure you stay dehydrated. That cures 2 things: UTIs and the chance of Braxton Hicks contractions. Now, we were all raised to drink 8 8-ounce glasses of water a day, but that method has changed in order to perfectly tailor your water intake needs. If you will take your weight and divide it in half, you need to drink that many ounces of water every day. So let's just keep it simple and say if a woman weighed 100 pounds, she would need to drink 50 ounces of water every day. All right, so let's talk about the warning signs of labor, when to call the doctor. Actually, when to probably just come straight to labor and delivery unless you just want to talk to your doctor first. If your water breaks, come straight to labor and delivery. If you have vaginal bleeding, especially if it is red and heavy like a period, that is an emergency. Come straight to labor and delivery. If your contractions become every 3 to 5 minutes apart and they're gaining in that intensity we just talked about, that's a warning sign. And anytime if you notice a decrease in fetal movement, always come straight to labor and delivery so we can put you on the monitor and check on your baby. Now, unless the loss of your mucus plug is accompanied by one of those warning signs, there's really nothing that you need to do about that. It doesn't necessarily mean labor is imminent just because you lose your mucus plug. All right, let's talk about what to expect when you arrive at the hospital. Remember, get registered first. When they bring you around to us, then it'll be all about meeting your labor nurse and getting settled into your labor room. We'll get you to pee in a cup for us and do a gown change. And something I want to tell you about that gown change is you've got to take everything off, okay? Bra, panties, jewelry, everything. Don't be trying to sneak in that bed only for later for us to discover you still have any of those things still on. As labor nurses, we're always thinking ahead. And for any reason, if this should turn into an emergency situation and we got to get this baby out really quick, it's not a good time with all the things you're hooked up to try to be getting that bra off. And none of those things can go back to the OR. So that's why it's best just to take all those things off at first. Okay, so then we'll get you settled into the bed and hook you up to the monitor. If you've never been hooked up to the monitor before, there's a top one and the bottom one. The top one monitors for your contractions, and this information is transferred over to your bedside monitor. We'll teach you how to read that. The bottom one picks up your baby's heart rate in real time. That information is also transferred over to the bedside monitor, and we will teach you how to notice everything that's going on in that monitor, and you'll be just as smart as we are by the time you leave. Then we'll have a time of signing consent forms. We streamlined that process a lot. Used to have to sign a big stack of papers like buying a car. Now you just sign your name on our computer iPad, so that's made that a lot easier. The first form that we will present you is an epidural consent form. And you may be one that's saying, well, I don't need to sign that because I'm not going to get an epidural. And that's perfectly fine. You are in control of your pain control. We work for you. It's not the other way around, and we will help you manage however you want us to do that. But what I tell my patients is I do encourage them to go ahead and sign that form just in case you change your mind. It could be that maybe labor is lasting longer than you thought it would. Maybe it's a little worse than you thought it would be for whatever reason. If you change your mind and you've already signed that form, that's going to keep us from standing there talking to you, explaining that form when you really don't want anybody talking to you at that time. So it just puts it on standby. It does not mean that you have to have an epidural if you sign it. So the next consent form would be visiting hours. On the labor side, we want you to understand that you're allowed to have 3 people attend your birth if you'd like that. They can come in and out all during labor because we never know when babies are going to be born. That will change when you get on the postpartum side to 2 visitors at the time, and visiting hours end at 9 o'clock. We do observe a snuggle and snooze time every day from 2 to 4 o'clock in the afternoons. Sometimes visitors can be overwhelming and you find that you just don't have any downtime, and it's really important that you have that special time. Maybe you need to perfect the art of breastfeeding. Maybe you're just tired. You and baby daddy want to just snuggle with baby and have your quiet time together. So that's why we set this time aside for that purpose. So please tell your family members so that they will understand ahead of time why we will not let them back between the hours of 2 and 4. No one under the age of 18 is allowed to come back and visit your baby unless, of course, they are your baby's siblings. Now, if this hurts anybody's feelings and this is like earth-shattering disappointment for nieces or nephews, please tell us. We will be glad to take your baby to the nursery viewing window so that they can see your baby from the hallway, and that makes everybody happy. One more thing about visitors. We will help you control your visitors, okay? Sometimes you find yourself in the situation that you get your positive pregnancy test in the very beginning, and there's somebody there in your social circle that lets you know everything is going to be fine. You won't have to worry about a thing because they're going to the delivery room with you. And you're looking at baby daddy like, I don't want her to go to the delivery room with me. And he's going to tell you what every normal male says. Well, just tell her you don't want her to go to the delivery room with you. But you know you can't say that, and you tell him, I can't tell her that. Well, it creates a situation of dread. Instead of looking forward to your big day, you just dread it because you really don't know how you're going to handle that situation. Please, please, please find a way to tell us on the side, and we will handle that very discreetly. We're very nice about it. We can custom tailor you a little medical diagnosis that says she needs to go, and she'll never know that you had anything to do with it. So please don't be worried about a situation if you find yourself in one like that. Okay, so the next consent form would be the safety precautions checklist. We go to great lengths at Colquitt Regional Medical Center to let you know that you and your baby are completely safe here at all times. So this form will notify you about our security bracelets. As soon as baby is born, baby gets bracelets on both ankles. Those numbers are exactly alike. You get the other bracelet, and whoever you would like to wear the other bracelet, we can give them one too. Everybody's numbers are the same. The nurses every single time without fail will always verify baby's number with yours, and you will always know that is your baby every time. Baby will also get another bracelet on one ankle that looks just like this. When we activate this little box will have a blinking light on it, and this is our security system. So when you're busy changing clothes and diapers, don't let that lose contact with the skin, because if it does, it's going to do its job and shut our unit completely down, lock all the doors, and turn our alarms on. If baby was to get in any unauthorized areas on our unit, it will do the same thing. So that's a very good method that we have in place for keeping baby safe. Also, everybody at this hospital wears a name badge. We are different in labor and delivery because we are the only ones who have little storks on our name badges, and we'll show those to you. No one is allowed to transport your baby without that stork on their name badge. We would never send anybody to get your baby for us, okay? So that's another way. All right, so the next consent form would be the hearing screening consent form. It's wonderful to have your baby's hearing, to know everything's fine with that before you leave the hospital. It's a very non-invasive little test. I do want to say that if for any reason your baby fails on one side or the other, please don't panic over that. It usually means that there just hasn't been enough time after delivery for the fluids to have cleared those little ear canals. So all we would do is just reschedule that appointment for a week later. You come back and usually everything's fine. The metabolic PKU test is also a consent form, pertains to baby. We will show you a paragraph, big long words that no one knows how to pronounce. They do represent rare metabolic disorders that cause mental retardation, but it can be reversed if we know about it. So all that little test is a simple little heel stick. We collect 5 little spots of blood on special paper, and we send that test off. Your pediatrician will review those results for you when you go. So your baby will be in line for all kinds of vaccines all over the first 2 to 3 years of life. The first one starts at birth. It is the hepatitis B vaccine, so you will have an opportunity to sign that consent form. It is a series of 3 vaccines. The first one's at birth, and your pediatrician knows when to follow up with the other 2. If you're having a baby boy and you want to circumcise, we will let you sign that consent form. That circumcision procedure will be performed before discharge, and we'll teach you all about how to take care of that. The last consent form, finally, is the car seat consent form. When you sign that, you are just saying that you understand baby needs to leave the hospital safely buckled in a car seat. One thing about that car seat is, baby daddies, please go ahead and take the base of that thing and install it in the car ahead of time. I promise you, mom and baby are not going to like sitting there watching you try to figure that out when they are ready to go home. One thing we would like you to know is that you cannot video or photograph a birth in process, okay? We know how important these pictures are, and after it's over with, if we're not dealing with an emergency situation, we definitely want you to be free to take all the pictures that you want to, and we can even help with that. But be mindful of those photographs. There is a lot of exposure at delivery. Okay, so after the consent forms, we will have a time of doing your admission questions. It is a common thing to bring your family members and friends with you on admission to the hospital, and that's perfectly fine. But I'd like to take this opportunity to encourage you to please have them sit in our little waiting room outside our double doors until we get through this process, and then we'll be glad to go get them and let them join you. When we go to ask these admission questions, there's a lot of sensitive information that we ask you, and we just want you to feel free, to feel safe in a confidential environment where you can give us the correct answers to these things, plus the opportunity to be open with us and tell us anything that you feel like we need to know that will help us take excellent care of you and understand your unique situation. So it is very confidential and very safe, and we look forward to establishing that relationship with you as our patients. So just know they're welcome to sit in the waiting room, and we'll get them afterwards. After that time, we will do your assessment. We will review your plan of care, tell you everything we're going to do ahead of time. We do initial blood work and start your IV when you come in. Mainly the blood tests that we do on admission are a CBC, because we want to know when you come to us what is your hemoglobin level, because we're going to compare that again the day after delivery to make sure you didn't lose too much blood during your delivery. Also know that you're treated like royalty once you arrive at the hospital. There are always people working behind the scenes on your behalf. That includes our wonderful staff over in the lab. During that, one of the blood tests that we will take is a type and screen, and they will get busy matching blood perfectly to you, putting your name on it and setting it aside. It is available for you the entire time you're at the hospital in the event of an emergency. If a nice little lady appears at your bedside asking if you want to donate your placenta, don't look at her like she has two heads. She is simply partnered with the company that we work with called Telligen. It is amazing what placenta tissue can be used for these days. It especially benefits burn victims. So there's no right or wrong answer to this. It's simply yes or no. If you say yes, you won't get a thank you note in 6 months. And if you say no, she won't get mad and slam the door when she leaves. So feel free to answer however you feel at peace with doing that. Okay, we'll also do a pelvic exam, because we need to know where you are in the scheme of things. Are we starting from scratch? Have you already started to dilate? If you're there for an induction, we will administer those orders at that time. Once you are being induced or you're in active labor, you will be given a clear liquid diet at that time. And that just means we order a clear liquid diet tray for you 3 times a day. More often if you need it. Anytime you want Jell-O, popsicles, or anything to drink, you just tell us. We'll be happy to get that for you. While we're on the subject of inductions, let's talk about 3 common methods that we use to get labor started. So, take out your little cervical effacement sheet in your folder. I like this one. It's my favorite picture. It includes a picture of the mucus plug. We've all heard of it, but nobody really knows what that is. And you can see that it's just a little gelatin-like substance that's situated there in the cervical cuff. It protects baby on the inside from everything on the outside. So that just gives you a good diagram of what that is. Okay, so the first picture on there shows the cervix, how it's not effaced at all or dilated. It's what we call long, thick, and closed. We can also use the analogy of the neck of a Coke bottle, the neck being your cervix, so the goal in thinning out is to shrink the neck back up to the bottle. You can see in the second picture where the cervix is 50% effaced, and the last picture, it's fully effaced, the cervix is completely gone. So, if you come to us and you are a candidate in the first picture there, long, thick, and closed, we have 2 medications that we can use called prostaglandins. The first one is Cervidil. Cervidil is like this little medicine on a paper tab attached to a string, kind of like the tampon effect. We insert that way up behind the cervix and leave it there for 12 hours. The other medication that we use is in pill form. It's called Cytotec. It's inserted also, and you can have Cytotec every 3 hours up to 4 doses. With the goal of that, again, is to thin that cervix out. When this treatment is over, we usually follow that with what we call Pitocin. And Pitocin is just a little bag that hangs on your IV pole, and we administer that in little tiny little doses. And the goal of Pitocin is to make your uterus contract. We want to establish a regular contraction pattern every 2 to 3 minutes without stopping. So that's how we use those two particular things. If you were to actually come in maybe dilated to 4 or 5 centimeters, you're having contractions every 15 to 20 minutes, another one in 3 hours, another one after dinner tonight, we're probably going to start Pitocin so this thing doesn't take forever. That'll help speed things up. The third common method that we use is called the Cook balloon, and we use this one a lot. We have great results with it. This is a Cook balloon right here. So the Cook balloon works by the gentle and constant pressure from the internal and external cervical channels. The way this works is you can see that it has 2 little pouchy places on it. The first little pouchy area we insert right inside the cervix and we inflate it like a little water balloon. The second one stays on the outside. We do the same thing. We inflate it like a little water balloon. So we've created kind of like a cervical sandwich with pressure above and below. The beauty of this is it stays in 12 hours, and hopefully by the time it comes out, you are dilated all the way to 5 centimeters. So that's halfway, and we think this is a pretty good deal, okay? I will say that the Cook balloon is pretty uncomfortable at first, okay? I just want you to know what to expect. Most women, not everybody, they complain of just this overwhelming sense of pressure, of course. So we want you to know that if you give it a chance, within usually 20 to 30 minutes, most patients acclimate to it and you really don't notice that pressure anymore. So just be open-minded about it, give it a chance, and let's see what happens. We have great results with it. If you believe you never acclimated and you're having a near-death experience with this thing, please, please, please tell us. We have lots of options to help you change your mind about the process, okay? So just let us know. All right, now that I talked about induction, we're going to back up and we're going to talk about why you should wait and go into labor on your own. It's just because some things are really worth waiting for, and letting labor begin on its own is almost always safer and healthier with better labor and delivery outcomes rather than scheduling an induction. So let's talk about elective induction versus medical inductions. There is a difference. Now, when you get to the end of your pregnancy, you are just going to be plain done with it, okay? It's been a long 9 months. You're going to say sleep is difficult, moving around is challenging, sometimes the worrying starts. The idea that you could just push the fast forward button and be done with it at 39 weeks, now that's downright tempting, and we understand that whole scenario. But pushing that fast forward button may actually be pushing the pause button, because induction of labor should not be taken lightly, and you need to know the risks and make an informed decision before you are seized with that irresistible temptation. Inductions can actually take 2 to 3 days and sometimes doesn't work at all and results in a C-section. You have to remember that inductions are trying to convince your body to do something it may not be ready to do yet. So ask your provider these very important questions, and remember, with elective inductions, you still have the right to make your own decision about it. Ask them, why are you recommending this induction? Is this induction likely to be successful for me? And the third question, very important, is my cervix ripe? Are we starting from scratch, or have I started to thin out any? Because women who are induced before their cervix is ripe have a higher chance of C-sections just because of those non-favorable conditions. Lastly, ask, are my baby and me healthy enough to wait for labor to start on its own? Your providers want you to be at peace with your decisions, and they are happy to talk about it and answer any questions that you have. Now, if you are scheduled for a medical induction, you gotta forget everything I just said, okay? Because there are definitely reasons that inducing labor is way safer than waiting for labor to start on its own. And there's lots of reasons. I'll give you just a few. Say your water has broken and maybe labor just fails to start on its own. We gotta do something. Say your pregnancy goes past 41 weeks and you're at risk of being pregnant forever. We got to do something. Conditions like preeclampsia and diabetes have a direct effect on your baby, so it may be a medical induction is way better. If you have an infection in your uterus, or you've been told your baby is growing too slowly, those are all just a few examples of why medical inductions are definitely necessary. So again, just talk it over with your provider and never hesitate to ask questions. When you are able and can let labor start on its own, you can be more confident that your baby's ready to be born and your body is working the way that it should. Okay, let's talk about some common equipment that you will see, stuff we use in labor. Every room is equipped with a birthing ball. You're more than welcome to utilize that. It's great for use before you get your epidural. The goal with birthing balls is to apply pressure on that cervix. We do have a peanut ball. That's for great use after your epidural. It's made out of the same stuff the birthing ball is, but it's just this giant shaped peanut that we can use for all kinds of different position changes. We can turn you on your side, put it between your legs, and we can flip you side to side every 30 minutes. That is just going to help keep the pelvic outlet open. It helps baby descend down better. We love our labor beds. We've got great ones. They are all equipped to reposition to a sitting position, just like I'm sitting up tall with my legs down. We can make your labor bed do exactly the same thing. They all have trapeze bars that go up, across, and down. We snap those into the bed. It's great for leaning forward, and we can show you ways to use that as well. All of these things facilitate a change in pressure, which speeds up labor and provides comfort and relief, instead of just laying flat in the bed the whole time. Then there's your delivery table. At some point in time, your labor nurse will come in and set up your delivery table for you. Don't be intimidated by the things you see on it. Most of those things are never even used, but we do have everything there in case of an emergency. All the labor rooms have radiant warmers for baby. They are fully stocked and equipped with oxygen, suction, and everything like warmth, anything we need in an emergency situation. Another common tool that we'll use is called the Amy hook. If your water doesn't break on its own, your provider just might come by and do that for you. All this is grandma's knitting needle in a sterile package, and that's exactly what it looks like. So he would take this Amy hook, insert it, and just nick a little hole in the amniotic sac, and out comes all of the fluid, and you can consider your water broken at that time. This also can speed things along, but it does put you on a 24-hour notice. It is best to have your baby within 24 hours after your water breaking, but if baby's doing well and everything's fine, we can extend that time frame as well. Okay, now that I have traumatized you with induction methods and the Amy hook, all of those things, it's time to discuss everybody's favorite topic called pain management. So we do have 3 pain control options that we utilize. The first one, believe it or not, is called natural childbirth. We call that non-medicated coping measures. We have patients who are very, very self-disciplined about this approach. They bring their labor support coaches and doulas in. We're good with that. We welcome that. These are people who are trained in massage and therapeutic touch. They know how to utilize movement like walking around and alternating positions, warm showers and baths while you're still at home. They teach you focused breathing. We use heat and cold application. If you want to bring your aromatherapy diffusers, we love those as much as you do. That's perfectly fine. And we create environments like dimming the lights and utilizing soothing music. Anything that you want to do through the natural childbirth methods is perfectly fine. I have 4 children. I made the decision and did natural childbirth too with my first baby. It went great. Everything was just like I thought it would be. It was wonderful. I loved it so much. I had an epidural the next 3 times. So there's only one way to see if something is for you, to just try it. We are strong supporters of natural childbirth. So if that's what your passion is, we're going to help you hack the system so that your birth is manageable and not something to suffer through. But I do believe that is our approach with every birth, whichever way you choose. The second pain control option is IV pain medication. We use Stadol and Nubain, whichever one is not affected by a national shortage at the time. I think right now we're using Nubain. You can have that every 3 hours in your IV, and it works great in early labor. Now, it will not take away your pain, but at this time, it's going to be easy to manage because it's just going to help you rest through these contractions and not be bothered by them. Eventually, you're going to tell us that pain medicine just isn't getting it like it used to, okay? So as labor progresses, there's nothing we can put in your IV that's going to take away your mind off of those contractions. So that's when most women do opt to get their epidural, and that's our third option. Now, there's a lot of risk to epidurals, but we want you to know that these are either very rare and everything about them are completely manageable. The most common one is low blood pressure, but it's going to be that way with any anesthetic procedure, so that's why we give you fluids prior to that to stabilize it. You could have numbness to your lower extremities, which makes it impossible to get out of bed and go to the bathroom, so we will use a Foley catheter and bedpans for that. Some of the side effects that are common are nausea, which we have medicine for, itchy skin, and sometimes you get little shaking like you're freezing to death, but we have warm blankets to soothe that as well. There is a possibility of a spinal headache afterwards. That is rare, but it is also perfectly treatable. So let's just forget about those minor setbacks and talk about the good news about epidurals. It will allow you to let go of the side rails and relax. I have seen women deliver a lot faster just because they stayed so locked up and tense fighting that pain for so long that once we got their pain under control, baby was just able to come down better. So it can promote progress in a previously slow labor. It's not true that epidurals slow labor down. They have changed the kind of medicines that they use in those over the years. And since you don't know how long labor will last, you can stay relaxed, alert, and stress-free for the possible long haul. Epidurals are usually generally safe and effective, and we don't turn them off until after baby delivers. But in saying this, I do want to stress that sometimes epidural placement is not perfect. It is designed to take away the discomfort and cramping of all of those contractions, which is the worst part, but it does not take away the pressure sensation of a tiny human coming out of your body. It's going to help with the Foley catheter insertion, and you will be aware of vaginal exams, but you will no longer be bothered by them. But sometimes, for whatever reasons, epidurals may not provide the coverage that you had your heart set on. So there's no guarantees, except we do guarantee we will work as hard as we can to make you comfortable. Sometimes they work better on one side than they do the other. Sometimes it can start off fine and you could get a lingering hot spot somewhere, but it could be that you're just getting really close to delivery and the pressure is overwhelming, and if that happens, that's going to be helpful when it's time to push. You can have your epidural when you're in active labor, but do take this window of opportunity very seriously because you cannot get an epidural at 8 centimeters and beyond. We cannot administer the IV pain medication anymore after 7 centimeters either. Now, we're not trying to incorporate cruel and unusual punishment here. It's just because when our babies are born, we like them very awake, very alert, active, great muscle tone, and crying. When we give pain medication, even though it's safe for you and baby, it has the same effect on baby that it has on you and can make baby sleepy. So we don't want this limp little baby and we're standing there wondering, is this pain medication related, or do we really have a problem here? So that's why we have to cut it off at some point. Something else to remember about the epidurals, your visitors are not allowed to stay in your room during this time. Anesthesia will come in and set up a sterile field for that, so that's why we send visitors to our little waiting room. Your labor nurse will absolutely stay with you the entire time, talk you through the whole thing, and make you comfortable. As soon as we get you settled, we'll bring your family right back in. Okay, so all of that leads us to the big day or night, because you never know when true labor kicks in. If you want to take a look at the blue and white page, that explains the labor process. It lists all the stages of labor on this. The first stage of labor is divided into 3 categories. Early labor, which is 0 to 6 centimeters, and that's kind of divided into 2 phases. It's not on your sheet, but the mild phase of early labor is 0 to 3 centimeters, and the moderate phase of early labor is 3 to 6 centimeters. Active labor is when you dilate from 6 to 8, and transition is the last little stretch there going from 8 to 10. But the first stage of labor is all about the thinning and opening of the cervix. So I have a visual that tells you what early labor looks like. Here she is. She looks great. She's got her hair fixed, her makeup on, smile on her face, her color's good. That bag is loaded down with everything because we know that you cannot wait to get to the hospital to see us. Everybody comes in feeling great. If only the rest of laboring was this easy. Now this phase is going to be perfect for the 8 key labor positions that are proven to help labor progress. You have that page also. So get to know these positions, do those at home, bring it with you to the hospital. We can help you continue doing these while you're there with us. Depending on which method is used to get from 0 to 3, inducing labor, or it's starting on its own, this should be a relatively mild and somewhat easy phase to accomplish. Most of this phase is done at home, and many women are already 2 to 3 when they come in. Now let's review the benefits of staying home as long as possible. There's lots of things we can do at the hospital to make laboring fun, and we will, but the ability to move around freely is greatly reduced with the medical interventions we have to do, like being hooked up to the monitor, the IV pole, not being able to get out of bed after your water breaks, and of course, obviously, those key labor positions become impossible after your epidural. So, with the possibility of early labor lasting anywhere from 6 to 12 hours, sometimes 24 hours or more, it's best not to jump the gun and fly to the hospital when you can remain at home and be comfortable in your own environment and rest and relax, go get a pedicure, drink plenty of fluids, eat anything you want to eat, go for short walks, utilize those key labor positions, take a warm shower and bath, and watch good movies. Baby daddy, if you're watching, she is still this person, okay? So be sure to offer comfort and reassurance, help time the contractions, and keep her mind off of labor with simple activities. You've got a big role to play. So both of you just keep calm and labor on. You'll know when to go to the hospital with the onset of the moderate phase of early labor, when contractions are roughly 3 to 5 minutes apart, last for 1 whole minute, and have been that way for 1 to 2 hours. However, we want you to listen to your body. If you feel it's time to come see us, please, please, please follow that instinct and don't take any chances. One more thing to remember is at about 36 weeks, your visit over at the office, they're going to do this little Q-tip test down there, which is going to test you for Group B. We need to know if you're positive or negative for Group B. If you test positive, that's not a horrible thing, Women all over the world are positive for Group B, and it just doesn't matter until the time of pregnancy and delivery. It would be devastating for a baby to come through a birth canal where Group B is present. So what we want you to know is if you end up being positive for that, don't try to stick it out at home, because we need you to come in and get your antibiotics. It's perfectly treatable. You will get them every 4 hours until the time of delivery. What's important is that you get at least 2 doses of your antibiotics before baby is born. That's going to keep your baby from having to have a septic workup to see if there has been exposure to Group B. So when you go into labor, keep that part in mind if you end up testing positive for Group B. Okay, so the second phase is active labor, going from 6 to 8 centimeters. A lot can be said about this stage, but the next visual just sums this whole thing all up. Here we go. So you remember when we talked about the longer, stronger, closer together? You are here. Now, baby daddies, I'm sorry, but I just want to warn you, this person comes out of nowhere, okay? Sometimes that's just the way it is. This mess that she finds herself in right now, it's going to become all your fault. No matter how nice and attentive that you've been all day, this is probably going to be your time frame to take a more hands-off approach, find another place to stand. We do know how to get her settled. It's going to be fine. We know how to refocus her, so just hang in there, okay? This moderate phase of early labor, remember, is the time frame that most moms get their epidurals, but remember the active labor is the last call for that. Your provider might also choose to come in and break your water at this time. Like I said, contractions now have become more painfully organized, but these are the ones that are going to dilate you to 8 and beyond. And do keep this in mind that this person usually disappears after the epidural, so there is hope ahead. Okay, moving on to transition, 8 to 10 centimeters. This is usually the quickest phase of the whole process, but nothing is going to seem quick to you at this point. You will begin to feel sensations of pressure as baby begins to move down with the squeeze of those contractions. When you feel a change in pressure, let us know and we'll check you to see where baby is. And you're like, what do you mean where baby is? When we do those vag exams, we collect a lot of information, and you've already learned about the cervical dilatation going from 0 to 10. You've learned about cervical effacement, thinning out from long, thick, and closed to 100% thinned. So if we check you and tell you that you are 10, 100%, and 0 station, you could actually start pushing at this point. But we are probably going to use this little phase called laboring down because you're only at 0 station. Station is a measurement of baby's head coming down into the pelvis, and like I said, we collect that information when we do that vaginal exam. When we talk about laboring down, let's explain what 0 station means. Now, we have all kinds of landmarks and ways that we determine 0 station, but I'm going to make it real simple in layman's terms. Let's just say that when the widest part of the baby's head starts to come through the cervix, let's call that 0 station. So anything before that would be -1, -2, -3, which means baby's still way up high, still floating around. So 0 station is perfect with that head applied right where you need to be. But as baby's head starts coming through the cervix, it's the opposite. +1, +2, +3, 4 and 5 is delivery of your baby. So if we let you labor down, that means we're letting your contractions help move that baby from 0 station to +1 and +2, which is a much better vantage point to start pushing from. We're not saying that you're not going to have a lot of work to do. You will, but hopefully letting you labor down to +1 and +2 before you start pushing is going to help shave off a little bit of that time and effort. So that's what that means. Okay, moving on to the second stage of labor. This is all about your baby moving through the birth canal. We call this stage pushing. And oh my goodness, all of those vaginal exams, when we do the one that gets us to be able to ask you that $1 million question after we check you, when we say, are you ready to have a baby? You are going to be so excited about that you have finally arrived. You will feel like there's finally light at the end of this tunnel, and baby just needs to come to the light. So when it's time to push, we will remove the Foley catheter if you have one, and if the lights aren't already dim, we'll do that at that time. This just creates a better birth environment for your baby. Just remember, your baby has never seen light before, and it's just really blinding for babies to be born in those bright lights. So that's why we create that environment. It's also great for breastfeeding as well. We will transition your legs up into the stirrups. Move all your blankets away. So if you came in bashful, not wanting anybody to see anything at first, don't worry, you will no longer feel that way by this time. Your labor nurse will start the pushing effort with you. We will get your baby way on down and then call your provider to come finish up. We might even use mineral oil during this time. This is to improve the natural stretching of the perineum and the head coming down. The nursery nurse will also come in at this time and be part of your team. By now, you have a huge adrenaline rush going on. Hopefully, you're getting a new burst of energy, or you could be very tired if this has been a really long labor. Either way, you're going to be experiencing tremendous rectal pressure. And depending on the level of relief you have with your epidural, you may feel an overwhelming urge to push, like you just can't help it. If you're doing natural childbirth, it will definitely feel this way. So, when you start pushing, we're going to tell you to take a deep breath, and we'll work with you and coach you to teach you all about the pushing process. But we're going to tell you to take a deep breath, almost like you're fixing to jump in the water. Take a deep breath and hold it. You're going to push down for a count of 10, let it out, take another deep breath, push down for another count of 10, let it out, take another deep breath, the last count of 10. We're going to do 3 sets of those with each contractions, and you're going to rest in between them. So the secret of pushing is, if you will take that deep breath and keep your mouth closed tight, avoid screaming and saying I can't. Don't do any of those things, because as soon as you do that, you transfer all the pressure down here back up to your face, and that becomes a wasted push. You've got a lot of work to do, so we don't want you wasting any pushes. So take that deep breath and hold it, and just push down, giving it everything that you've got. When it comes to pushing, I always like to address the elephant in the room really quick so that we can just get these fears out of the way. And the elephant in the room is called poop, okay? We encounter women all the time who are just mortified at the thought of this possibly happening during pushing. So I'm just going to go ahead and nip this in the bud. Please, please, please focus on your pushing effort, not the possibility that poop is coming out. This happens to virtually all delivering moms, and all of us who attend births for a living understand this, expect this, and don't think a thing about it, okay? So if this happens, it's because you are doing exactly what we've told you to do. So we have everything we need to clean it away, change the Chuck's pads, and keep right on going. So hopefully you won't think about this again after this class. All right, let's address some pushing tips. Everybody likes to have help knowing what to do when it comes time to push. This is the part where you want to forget about your best friend who told you she only pushed twice and her baby came out, okay? That's not the norm. We hope that happens with you, but just be prepared that with first babies, you may push anywhere from 30 minutes to 1 hour or longer, okay? We want you to push, like we said, exactly like you're having a bowel movement. That's the exact pushing technique that you need to incorporate. It's easy to think about everything is right there in the front, but it's not. You're going to feel great rectal pressure and you push just like you're trying to push poop out. The reason you feel that rectal pressure is because in the very beginning, baby's head heads straight to the back, and that's why you feel that. As you continue to push, baby's going to turn and kind of pop up under that pelvic bone, and then it does become about all in front. So that's how that happens. You will be in a semi-sitting up position, so we're going to ask you to tuck your chin to your chest and just give it all you've got every single time. We'll pull your legs back even further in those stirrups, and that just kind of helps to open up things even better. Family members are certainly welcome to help hold those legs back. We're good with this. I will say baby daddies don't get too excited about this pushing part, okay? And that's perfectly normal if you find yourself in that category. Labor nurses are doing a lot of things during deliveries, and one of the things we're doing is we keep an eye on baby daddy over there, okay? We've had baby daddies pass out. We've had them go in the bathroom and throw up. I even had a delivery one time where a baby daddy just had a full-blown panic attack right in the middle of it. He flew out the door and missed the whole delivery. Now, I don't know what kind of trouble he got into for that later. That's none of my business. But I tend to kind of side with him because, you know, he did what was best for him. He did what he needed to do to get through that. So just understand if for any reason your panoramic full color view all of a sudden becomes black and white, don't try to be the hero. Go ahead and take a seat in the chair, kind of lean forward. All of that will return and we will help you get through that process, okay? Not to worry. Again, our labor beds are great. We have handles on them that can just pop up on the sides. Your hands can just naturally navigate to those handles. They provide great counter pressure while you're pushing. We call that kind of like a pull and push thing. It gives you leverage and it helps improve your pushing effort to be able to pull against those handles. So you're welcome to use those as well. We just want you to stay focused on seeing this baby you already love so much and have waited so long for. We're going to cheer you on. We want you to trust us and just try not to lose it. This stage can produce 2 words really quick, the I can't, but don't say that because you absolutely can. And very soon you're going to have this baby and it's going to be one of the most memorable and special moments of your entire life, I promise. So keep going, push hard, rest between contractions, and sip Sprite and ice chips in between. We call that refueling. That will help a lot. Okay, again, epidural, you might not, but natural childbirth, you definitely will feel what we call the ring of fire. If you feel that, the first thing that you're going to think is that you are just tearing from the front to the back, and it's going to be scary and it's going to make you stop pushing because that's what you're going to think is happening. That's not what's happening. And if you are tearing, it's weird how you'll never even know that that happened. What the ring of fire is really a natural burning sensation that is felt with the stretching of the perineum as the head begins to emerge out. So you got to push right on through it. That's how you cure it. It won't go away if you stop pushing. So just listen and do everything we tell you. Pushing is going to be the hardest work that you will do. And at first, you're going to feel like you're not accomplishing anything at all. It's kind of like 3 steps forward, 2 steps back. But pretty soon, you're going to feel that slippery, wet feeling as the whole body of your baby just slides out, and you'll have a sudden, immediate onset of it's over, and love at first sight will just overwhelm you. We've been doing this a long time. It never gets old. Every birth is a miracle, and you're going to have your own miracle pretty soon too. All right, so the third stage is the delivery of the placenta. Now keep in mind you just delivered head and shoulders. This part is nothing at all. It's just going to feel like this big giant blood clot squishy thing that comes out. It's going to happen anywhere from 2 to 5 minutes after your baby's born. Your provider will ask you just to give another few quick simple pushes, and that's over with. You'll have your baby in your arms and you won't even notice. The fourth stage is recovery. Now, the very first question after birth is usually, how much does my baby weigh? What we want you to know is that our hospital promotes the golden hour. It means that after baby daddy or any significant other cuts the cord, your baby will be placed immediately skin to skin on mom for 1 hour. We'll do a brisk rub down and put a diaper on. Don't worry about that. But this is going to be baby's time to recover also. It is a very beautiful time. It is amazing how skin to skin just transforms that baby into life outside of the uterus, and it is great. It helps regulate your baby's heart rate, their temperature, their blood sugar, their breathing ability. It allows that wonderful bonding to initiate right there in the beginning. It's going to promote breastfeeding success and reduce their little crying from being separated from you. So it's wonderful. And unless there's a medical concern, baby and mom should never be separated after birth, which all those routine procedures would cause to happen, like weight and all those other measurements. We can do vital signs and put those security bracelets on. All that can be done right there with baby in your arms. So expect that skin to skin golden hour. And baby daddies are welcome to do that as well. We don't mind at all. If you have stitches, we will get you an ice pack and meds for comfort, okay? We're going to teach you how to do the sitz baths and use the peri bottle while toileting. All of these things are going to help. Now, these stitches will dissolve on their own. You won't ever see them, and there's nothing to do about them. Even if you don't have stitches, you are going to experience the normal soreness and discomfort down there from after what you've been through. It's going to be difficult to sit down on surfaces and stepping up on steps for the first 2 to 3 days, but you will work that out relatively quickly when you are able to, get back to your normal activities. The next thing in recovery, vaginal or C-section, we will do strict monitoring of your bleeding. We're going to measure blood loss, and we do what we call fundal massages, rubbing that uterus to make sure that it returns to the size of a little hard baseball in the middle. We want it right there and firm. Doing those fundal massages help accomplish that. Your epidural will be turned off at this time, and you will regain sensation over the next few hours. It might take a while. But when this happens and your bleeding is stable, we will help you up to the bathroom to get all cleaned up, put on our signature stretchy underwear that everybody loves and that huge peri pad, and you will be transferred over to your postpartum room. Okay, so let's hit on the highlights of postpartum recovery, what to expect with that vaginal and C-section. After you get transferred over to your postpartum room with a vaginal delivery, in the process of doing that, you're going to get rid of that blood pressure cuff. You don't know what that means right now, but you will. You'll be able to shower on your own, wear your own clothes. We will disconnect you from the IV fluids, but you'll still have a little INT site, a little piece there that just allows us to be able to give you medicines if we have to. You'll have your blood drawn the next morning. At that time, if you're just sick and tired of that thing and don't want it in there, please ask us. We'll be glad to remove it. But if we take it out before it's time, just understand that if we need IV access again, we're going to have to start another one. So if that's okay with you, we'll be glad to take it out. We'll give you a peri bag with all of your supplies, teach you how to use the peri bottle, like I said. If you're not going to breastfeed, and we hope that you're strongly considering that, but if you're not going to breastfeed, we will put a breast binder on you wrapped up really tight. We need you to wear that breast binder for two weeks, non-stop, 24/7. Don't take it off except for taking a shower. And if you have a sports bra, something you can wear in the shower, we encourage that as well. Don't face the shower and let that water stimulate you. Turn your back to it. We want to do everything we can to stop your milk from coming in. And if you wear that breast binder for 2 weeks consecutively, you should be out of the woods for that. You will be promoted to a regular diet, which is good news. I can't think of a better meal in your entire life than the one you eat right after delivery. You are starving. You could hunt a horse down and eat him. I am not kidding. So eat whatever you like. We have great food at the hospital, but if there's something you had your heart set on, your family members are certainly welcome to bring food from the outside. Remember, your visitors will be decreased to only 2 at the time, and all vaginal deliveries get scheduled Motrin and postpartum meds around the clock. Now, if for any reason you had a C-section and you had a spinal for that, meaning that you were fully awake during your C-section, you will come straight back to us for us to recover you on the labor and delivery unit. And you probably are busy thinking, well, what do you mean if I didn't have a spinal, what else did I have? How does this work? So there's 2 reasons commonly that we would do general anesthesia in the event of a C-section. One would simply be because maybe we had plenty of time to do that C-section, but we just couldn't get the spinal anesthesia to work for whatever reason. I know you don't want to lay there and feel that whole procedure, so of course we're going to give you general anesthesia. Go ahead and get the thing over with and everybody's fine. If for any reason that this turned into a dire emergency where we got to get this baby out within 2 to 3 minutes, and don't worry, we absolutely can. We're not going to take the time to do a spinal anesthesia. We're going to immediately sleep you, get that baby out, and know that mama and baby are safe. So we don't recover general anesthesia patients on our unit. If that's the route you had, you would simply go to the PACU department, where they are very qualified and would love to take excellent care of you. And as soon as they get you settled, they'll just bring you right back to postpartum, and then all the things I just discussed will apply to you. You will have a Foley upon your return. We keep that in until you get up and start ambulating around. You have a special incision bandage. We give you an abdominal binder around it that is very supportive, and everybody likes wearing those. You can shower also once you're up and ambulating around. Postpartum meds, the same for you. You're on the same schedule, the routine meds. You do get stronger pain meds with the C-section. We think that's fair. Okay, so your recovery will go really well with us over on the postpartum side, and we look forward to you being on the other side of this delivery. Now, just like we talked about 2 conditions that can happen before pregnancy, let's end talking about 2 conditions that can happen after delivery that we want you to be on the lookout for those 2. We're going to review the signs and symptoms of, number 1, postpartum hemorrhage. Now, expect normal postpartum bleeding, okay? It's your body's way of shedding all of that built up uterine lining, all the extra blood that helped keep you and your baby healthy during pregnancy. You will have bleeding whether or not you delivered vaginally or by C-section. Although moms who have C-sections are likely to have less bleeding because all of that gets cleaned out during surgery. But the first few days, the bleeding is dark red and it's on the heavier side. Then 4 to 7 days later, it changes to pink and the flow is lighter. And after 1 to 2 weeks, if you haven't been overdoing it and getting the rest that we want you to have, it should lessen and go from brownish to a white discharge. Now, although this bleeding will seem like a period, we are going to tell you not to use tampons or have intercourse all the way up until your 6 weeks postpartum appointment. At that time, you can also discuss your birth control options then as well. So, Expect that kind of bleeding, perfectly normal. While it is very rare, postpartum hemorrhage can happen. This is when a mom has more bleeding than normal after birth and loses way too much blood. It usually happens within the first 24 hours after giving birth, but can occasionally happen over the next several weeks. If this happens immediately after birth, we do a rapid assessment. It becomes an emergency situation to identify where is this bleeding coming from. Is it coming from the uterus? Is it coming from the cervix? Is it because of a tear that we didn't see in the vagina? Why is this happening? The tone of the uterus might not be firm like that little baseball I talked about. It could have become boggy, or it could be from retained placental fragments. It could even be because of simply a full bladder. We look for all these causes and routinely do those frequent fundal massages to keep this from happening. That's why we do them. But we do have an emergency protocol and all the medications that we need to resolve this on standby, everything we need to do to stop this postpartum hemorrhage. Now, we are talking about free-flowing bleeding that doesn't stop. After giving birth, you will still be in bed for a while before you get up, so it's normal to have bleeding that comes out and stops. When you're finally able to get up and go to the bathroom, you may feel an initial gush, which is also normal because you've been sitting in that bed. The bleeding's kind of been pooling all this time, so when you get up, it has to go somewhere, and that's what causes that. But we're talking about bleeding that starts, it's free-flowing, and it does not stop. That's an emergency. It may even mean a trip back to the OR to stabilize it, and also results in a blood transfusion if too much blood is lost during this time. And like we said, everyone gets their blood drawn the next morning after delivery to make sure that your hemoglobin is still within normal levels. So, when you are discharged from the hospital, it's still important for you to recognize certain signs and symptoms of a postpartum hemorrhage. If for any reason you are soaking a pad every hour, you need to call the doctor. If you are passing large clots, that is also a problem. Now, you can expect small little clotting material like the size of a nickel, a quarter. Those things are normal. I'm talking clots the size of your fist or even larger. Those are not normal. If you were to experience extreme tiredness, experience dizziness and blurred vision, get belly pain that's new or worse, fast heart rate, all of those are emergency situations that you would need to get in touch with your doctor. Postpartum bleeding is not real fun, but remember, it is temporary and completely normal. We want you to take it easy and give your body time to recover because it's been working so hard for these last 9 months. We will also equip you with plenty of other postpartum warning signs on your day of discharge. We will go over all of that with you and tell you also other reasons why you would need to call or come back in. Okay, so one more very important one, something that can happen after delivery. We know that having a baby is a very happy and exciting time for you, that you've been looking forward to this for a very long time, but it can also be a very tiring and overwhelming one. Many new moms are surprised to find out that they just feel kind of sad and moody, and they don't really know why when adjusting to this new life. This can be very common and last for a couple of weeks. We call this postpartum blues. We want you to watch out for signs of being sad, grouchiness, crying, mood changes, trouble sleeping, lack of energy, not able to focus, maybe the onset of anxiety episodes. Now, some baby daddies are sitting there thinking, I know what y'all are thinking, she has been this way the whole entire time, and that's okay. But this should not be happening after delivery, okay? So we want you moms to be open about your feelings, get enough sleep. It's a great thing to be able to sleep when baby does. Eat healthy, ask for and accept help, find other new moms to connect with. All of these are great ways to get past this little 2 weeks of postpartum blues. If these problems do not resolve or get worse, you can't cope with your daily tasks, you feel hopeless and no longer have a desire to be around or take care of your baby, then it has evolved into something way more serious that we call postpartum depression. We want family members to be able to recognize these things because you as a new mom could just be sitting there alone in your own world feeling like a failure and nobody knows what's going on until something terrible happens. So you must get help immediately if any of these symptoms occur. I do know that pediatricians do a great job these days checking on moms just as well as they check on babies. So it's so good to know that this is a part of your time with your pediatrician as well. Okay, so this concludes my presentation as our lactation consultant has a beautiful and informative presentation about breastfeeding that she will do. Your folder has lots of printed resources, so try to spend time reading over it. It's our approach on how we would handle all the topics in there. Please feel free to call Labor and Delivery with any questions or concerns that you have. We never close and we would love to speak with you. You're also welcome to come over in person and take a look at our unit ahead of time if you want to. The takeaway that I want to leave you with is that we want your birth experience and stay with us to be exceptional and amazing. And we hope after the excellent care that we provide you that this is how you leave us. Better than when you first arrived. Thank you so much for watching. I hope you have a joyful journey through the rest of your pregnancy and beyond, and we look forward to seeing you very soon.